Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features a discussion of recently reported findings with the potential to impact the treatment of patients with Waldenström macroglobulinemia, mantle cell lymphoma, Hodgkin lymphoma, and diffuse large B-cell lymphomas. This episode is part of a larger educational program entitled Global Conference Coverage, Clinical Impact of the New Data in B-Cell Malignancies from ASCO and EHA 2020. During this podcast, Dr. Jennifer Brown from the Dana-Farber Cancer Institute in Boston and Dr. John Allan from the Weill Cornell Medicine in New York will discuss new data, including results from the Phase 3 ASPEN trial comparing the BTK inhibitors Zanubrutinib and Ibrutinib for patients with Waldenström macroglobulinemia, as well as findings from the KEYNOTE-024 study that compared Pembrolizumab with brentuximab vedotin for patients with relapsed refractory Hodgkin lymphoma. For more information on Dr. Brown and Dr. Allan, along with a link to the complete program, including a downloadable slide set, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
So thank you for the invitation to participate in this podcast with you today and my colleague, Dr. Brown. We'll start off with the ASPEN trial, which was presented at both ASCO and at EHA with updates there on the initial kind of reports of the study. And this was a trial of Zanubrutinib, head-to-head study, randomized phase 3, Zanubrutinib versus Ibrutinib in Waldenström's macroglobulinemia. And this was a study that was designed to show superiority of Zanubrutinib in terms of response rate, VGPR rates and CR rates. And so that's kind of how the study was designed and powered. And this enrolled mostly relapsed refractory Waldenström's, but did allow some treatment-naive patients, but was capped at the number of treatment-naive patients that could be enrolled, and they had to have contraindications to standard frontline kind of chemoimmunotherapy approaches, but patients were all BTK inhibitor naive. And so what we see here is the response rate, which was the primary endpoint of this study, shows that the VGPR and CR rate was a little bit higher for the Zanubrutinib arm, with showing 19 to 28% at the initial independent review committee, and basically kind of looked into trended towards this primary endpoint that the study was designed to show, but unfortunately did not actually prove to be statistically significant at that time point that it was shown. But with that said, it is an effective agent. It does have high response rates, and BTK inhibitors are very effective in this disease. And when you look at the IgM reduction and the survival from the study, you can see that depending on the drug you had, there was no real significant difference in terms of progression-free survival or overall survival. But again, there was a greater reduction in the IgM with Zanubrutinib versus Ibrutinib that was statistically significant. What was one of the most important things that I think came out of this study was the AE side effect profile, because this was the first time two BTK inhibitors, or at least a BTK inhibitor, went against kind of Ibrutinib to really see. Zanubrutinib, as a reminder, is a relatively selective BTK inhibitor, much in the vein of like an acalabrutinib. All of these drugs are irreversible inhibitors of BTK. But what you can see is discontinuation rates are relatively lower, and dose reductions are lower for the Zanubrutinib arm, so therefore showing you that it's a little bit of a better tolerated agent. And when you look at the AEs of interest, obviously the AEs that we worry about with BTK inhibitors are diarrhea, AFib, bleeding, hypertension, infection rates. What you see with Zanubrutinib is that the AFib rate was very low comparatively to Ibrutinib, with all grades 3% versus 18.4%, and grade 3 or 4 or higher was 7% in Ibrutinib, and mind you, AFib is one of these things. When it happens, it's not necessarily the grade, it's the fact that it happens. Sometimes you need to start anticoagulation and rate controlling medicine, so it has potential impact on quality of life outside of how the severity of the event. And so whether or not it happens or not is very important to our patients and to us as physicians. And so there was a rather stark difference between those two drugs and that AE specifically. And additionally, the other thing that kind of came out here was that Zanubrutinib seems to, in these Waldenström patients, have a higher rate of neutropenia. And so those are the big things to look for. You can see the grade 3 or 4 neutropenia rate for Zanubrutinib at 23% versus only about 8% with Ibrutinib, which for the most part in this study did not seemingly translate to febrile neutropenias or higher infections or anything like that, so it can be managed. But there will be GCSF use and things like that, and other potential complications that we'll have to worry about. So it wasn't completely all 100% in favor towards Zanubrutinib in terms of this AE side effect profile. And so basically what came out of the study was that Zanubrutinib did not meet its primary endpoint, though it was starting to trend towards significance. And I think we'll have to see, as we know over time, response rates do improve with BTK inhibitors. And so will this kind of start to continue to differentiate over time? The progression-free survival didn't seem to be any different, nor the overall survival between the two drugs, and that Zanubrutinib does show lower rates of other AEs such as atrial fibrillation, bleeding, diarrhea, hypertension, but we did have this higher rate of neutropenia. And so I guess, what do you think of that endpoint, Dr. Brown, of the response rate for this study?
Well, in general, I don't think response rate is the most informative endpoint, that progression-free survival is always better. But I really like the AE data, which I think are really quite clear as a proof of principle for second-generation BTK inhibitors really, in fact, being better tolerated. So it'll be interesting to see, as depth of remission hopefully increases over time, if in fact that translates into a greater difference for Zanubrutinib.
Yeah, I think I agree with you. I don't know if I'm aware that response rate necessarily has translated to this improved long-term outcomes in Waldenström's necessarily, but I do think many patients with Waldenström's do have side effects from the IgM levels, and the neuropathy, the vasculitis, and the viscosity issues, and so anything that can potentially deepen that from a baseline may have some potential impact on quality of life over time. And so there may be some value in getting a deeper response, although that may not necessarily translate to a longer, better long-term outcome.
That's a good point for sure.
So there's also some other exciting data. We've seen in mantle cell lymphoma using these triplet agents that we have already discussed, that we previously discussed within the CLL groupings, with these triplets of BTK inhibitors, BCL2 inhibitors, and anti-CD20. And so this was a study, the OASIS study, where this was basically a 3-cohort study. And in the relapsed refractory MCL patients, that has been previously reported. But what this specific highlight was in the treatment-naive mantle cell lymphoma cohort, which is obviously important as we start to learn if we can get away from chemoimmunotherapy frontline options for patients. Can we use this chemo-free, mostly oral regimen for our patients with mantle cell lymphoma and have durable and deep remissions and potentially spare patients toxicities of chemoimmunotherapy? So that's what this study is, and this is reporting on that cohort C, which is the treatment-naive patients. The primary endpoint was the MTD of the combination, and then obviously standard secondary endpoints. Now, it's important to note that this study had Ibrutinib continuing until progression, and the venetoclax went up to 24 cycles basically, and then the continual Ibrutinib. So there was this maintenance part of this. And as you know, as we do these early phase studies and the first ones in combination, it's always most important to look at AEs, as that was one of the primary endpoints here, is these DLTs. What we see, and I don't think there was anything necessarily specific or that jumped out at me that was a little bit unknown. You know, we are familiar with these triplet regimens, and it seemed very comparable to what we see with this and other disease histologies, these triplet regimens and other disease histologies, namely CLL. So very well tolerated. Patients did well, and essentially very low rates of grade 3, greater than grade 3 AEs. So what was exciting was that the response rate at the end of cycle 6, where we started to have our first response assessments, and basically, we saw very deep remissions. We saw deepening remissions kind of over time as you got into the triplet regimen, and with CR rates pushing 80% and very high rates of MRD negativity as well in the peripheral blood. That that translates, as we know, if there's a high concordance rate between peripheral blood and the bone marrow negativity. And so this was using ASO PCR techniques, looking at relatively deep remissions and basically high rates. So we see the same synergy in mantle cell lymphoma that we do in CLL, and patients were doing very well in getting into these deep remissions. So, just to summarize the study, it demonstrated a very good safety profile, very consistent with what we know, and basically 80% of these patients achieving MRD negativity with 1 year PFS, in 90% range, and same with overall survival looking very, very good. So, Dr. Brown, so what do you think of this MRD and mantle cell lymphoma? Do you think this is somewhat of a different disease and a different biology to where we'll ever be able to stop treatment? Not mind you, this was continual therapy with some maintenance of the BTK inhibitors, or do you think we can maybe get to a point where we might be able to give a finite duration for our mantle cell patients, much like we do with chemoimmunotherapy approaches for them?
Yes, that's a really interesting question, isn't it? Certainly with some of the prior Ibrutinib venetoclax studies, patients achieved undetectable MRD but still relapsed relatively quickly. Mm-hmm. I like the idea that they're giving long duration sustained therapy here, even though they're achieving undetectable MRD. That seems a first step to assessing the benefits of undetectable MRD in this setting. It's not clear to me that we'd ever be able to stop. Although certainly, patients who have chemoimmunotherapy followed by auto can have very deep and durable remissions for many years, right? So perhaps if you can achieve that level of cytoreduction and depth of remission, you could stop. What do you think?
Yeah, I agree. I think that MCL may be a little bit of a different disease to where, these MRD negative responses can relapse. And if you're stopping treatment, they can relapse relatively quickly, much like what we see with the 17p deleted patients in CLL. And so, I think there may need to be some type of continual pressure put on the disease. I do, I am encouraged by this. This is not the only oral regimen, R squared with lenalidomide and frontline mantle cell lymphoma has been reported now out 4 years with very good progression-free survival rates. And so I do think there, outside of relatively high-risk patients, we might be able to start to select patients that could do very well with low toxicity with these oral regimens. So I think it's coming around, but I do think that that question of stopping in them is probably not completely the best way, and makes MRD and mantle cell lymphoma a little bit, questioning the value of it in a sense, because if patients are going to relapse, even if you're getting to that deep of a remission, what does it really mean? So But I'm encouraged by these chemo-free options, and that was exciting data to see for sure. So trying to cover all the disease histologies here. This was a pretty cool study that is reported out with relatively long-term follow-up by the German Hodgkin study group looking at HD17, which was a study of PET-guided therapy for early-stage unfavorable Hodgkin lymphoma. And so basically the standard of care, at least when you watch the presentation in Germany and with the study group, their standard of care for these early stage unfavorable, stage 1, 2 unfavorable, bulky or multiple lymph node sites or based on your ESR is how you assess unfavorable disease with early stage. Their standard of care basically became BIACOP, escalated BIACOP times 2, with ABVD times 2, followed by radiation therapy. And that seemed to have improved outcomes over just 4 straight cycles of ABVD plus radiation therapy for these high-risk early stage unfavorable Hodgkins. And so this study started to incorporate what we know, where you want to now have a PET-adapted study and potentially spare radiation therapy in these patients who might be able to get to PET negativity. So this enrolled patients into 2 arms. One was just a standard chemo multimodality therapy where they got the standard of care, 2 escalated BIACOP, 2 ABVD, followed by 30 gray involved field radiation, regardless of what their end of treatment PET response was, versus the PET-guided arm where they got the same induction chemotherapy. And if you were PET negative, you avoided radiation. If you were PET positive, and it's important here to note that the Duval score 3 was considered PET positive. So 3 or 4 or higher, you were PET positive, and you got 30 gray of involved field radiation in that randomized arm. Primary endpoints was progression-free survival in the patients with and it was basically designed as non-inferiority. And then the second endpoint was overall survival in the intention to treat arms or population. And so what did it find was that it seemed that PET-guided treatment was non-inferior to the standard multimodality chemotherapy radiation regimen, where 5-year PFS was very similar, 95% compared to 97%. So these are the patients who were PET negative at the end of that induction chemotherapy. And if you're end of PET negative, you can seemingly avoid radiation and not have an inferior outcome in terms of progression-free survival. What was interestingly in that in the study that was in the presentation was that the PET positive patients, the patients who had the worst survival, even with radiation, were the Duval 4 patients. So the Duval 3 patients actually did very well, and essentially those were the high-risk patients, were these Duval 4 patients at the end of therapy. So basically the next hypothesis that was generated was trying to understand how better to identify who those patients are going to be. And essentially that's what kind of some of the questions that came of this study. And then as you can see here, again, overall survival, there is no real difference in the PET-guided patients versus the standard chemo modality patients, and very similar overall survival. So some of the endpoints here were that you can seemingly safely stop PET-negative patients after this escalated BIACOP ABVD combination therapy and radiation in these early stage unfavorable patients, and that we need to do a better job for these patients who appear to be completely refractory to that induction therapy. Otherwise, it's going to probably save a lot of patients radiation therapy. So Dr. Brown, I think in the U.S. we don't use that much BIACOP, and I think we are less hesitant to do this. Once you've seen this data now, is this something that you think you'd be employing for some of your patients and or at your center?
I think the toxicity of BIACOP is such that we're still not really using it.
Right.
It is nice to see the radiation sparing here.
Yeah, I agree. In this study, they did make a point that, in terms of fertility and at least at this time point, secondary malignancy rates and things like that were really no different in the ABBD arms from that previous study. And so, there was some credence that if this abbreviated course, you might be able to spare it. And then obviously sparing the radiation toxicity is important about it. I think, in the presentation, the presenter stated that this is kind of now the standard of care for their group. And it's kind of interesting to see how this will trickle out, as this is fresh data as the publications come out, so on and so forth, and see how the rest of the world starts to adopt the data. So this next study that will stay in the Hodgkin lymphoma realm, this next study was the Keynote 204 trial, which was looking at Pembrolizumab and brentuximab vedotin in relapsed refractory classical Hodgkin lymphoma. And this study design was a phase 3 open label randomized study for patients who relapsed after auto stem cell transplant or who were ineligible for auto stem cell transplant and had failed one prior therapy, so kind of truly primary refractory type patients. And of note, you could have had prior brentuximab, but only a very few number of patients actually had prior brentuximab. So this was relatively clean and straightforward in terms of head-to-head data here. And then until progression or up to 35 cycles of treatment. And basically then the primary endpoint was progression-free survival. And then secondary endpoints were investigator response, PFS, as well as overall response rates, duration of response, safety, and kind of standard secondary endpoints. And so what the study showed was that the patients with post-stem cell transplant enrollment here showed that pembrolizumab therapy had improved progression-free survival. And you can see there at month 12, it was 53.9% versus 35.6%. And this was statistically significant. And the median was right around that one year mark for Pembro, is about 8.2 for BV, and the hazard ratio was statistically significant. And similarly, the PFS by the investigator was corroborative to that outcome and endpoint as well. When you looked at the subgroups, basically every subgroup for the most part favored the pembrolizumab PD-1 antibody approach as the first kind of treatment post stem cell transplant relapse, and essentially you can see there the forest plot there favoring the pembro for the subgroups. And when you look at the response rates, you start to see some differences here, where the overall response rate was a little bit higher, 65.6% versus 54%. And while most the CR rates were relatively equivalent, you started to see it in that partial response difference there, and making up that overall response rate difference. And then when you look at the people who did respond and how long did they respond, they do seem to respond a little bit longer in terms of the pembrolizumab arm. And importantly, the toxicity differences, and obviously these are two very different classes of drug. One is a PD-1 inhibitor antibody, the other is an antibody drug conjugate with an MMAE kind of drug warhead on there. And so not surprisingly, we saw toxicities are attributed with each one, and basically differential based on which drug you got, whereas major toxicities for brentuximab vedotin and basically a dose-limiting toxicity in terms of how much you can deliver is neuropathy and kind of some GI side effects, whereas with the PD-1 antibody, you start to see kind of the hypothyroidism, the pyrexia, and some of these kind of more immune inflammatory type of related side effects. But overall, low grade and pretty well tolerated. So the summary of the Hodgkin lymphoma shows that, in HD17, you could potentially eliminate radiation therapy for PET-negative patients with the escalated BIACOP ABVD combination induction therapy, and there was no significant difference at 5-year progression-free survival or overall survival rates. And then on the Keynote 024 study, it does appear that Pembrolizumab seems to be a better agent in terms of progression-free survival for these patients that are post-stem cell transplant. And from my understanding and my interpretation of that, seems to be the preferred first choice of treatment for a patient that is post-stem cell transplant that's been naive to either agent. It seems to make sense to be going with the PD-1 inhibitor at that point in time.
There's certainly an impressive difference in progression-free survival favoring the Pembrolizumab. I was wondering how much of it was due to delivering the therapy. Did the neuropathy limit the brentuximab administration?
Yeah, so I looked at that and it did not look like that there. So the discontinuations in the brentuximab arm, I think a third of them were actually due to progression of disease and not due to toxicity. And so I was expecting to see what you are alluding to is that the neuropathy or whatever limited the ability for the patients to get the drug. They had dose reductions or they just, had to stop it. And then therefore that translated into a progression. But when you actually looked at the data from when I looked at it in the presentation, it did appear that, these were true progressions on the drug rather than progressions off of the drug just stopped due to a toxicity. So I had that same question, and so that was impressive to me to see that. And so here's the last study that came out, and this is kind of a cool study and a cool concept, and it'll be great to hear Dr. Brown's thoughts on this too. This is the Alexander study, and this was the looking at a bicistronic CAR T cell therapy in relapse refractory DLBCL. And so what does that mean? Well, that means basically these CAR T cells are now modified not to just target CD19, but they're also modified with a CD22, which is also another B cell marker that is kind of a ubiquitous B cell marker like CD19 and is upregulated on these B cell malignancies. And so one of the big issues in the field is how do we avoid resistance to CAR T cells? How can we get more and more patients to respond? Because it really looks like, in DLBCL with the conventional CD19 CARs, the response rate's relatively high in this relapse refractory population, but the CR rate's relatively low. And basically, if you don't get there, or if you have bulky disease, or if you have high LDHs, these are all predictors for early failure, where you can have an initial response. It might be partial in nature, and then all of a sudden, 3 to 4 months later, you're blowing through it and progressing. And so this study is trying to attempt to address that situation of how can we activate and target two potential escape mechanisms by CD19 loss. In addition, this study started to employ pretreatment with Pembrolizumab, a PD-1 inhibitor, to basically knock out the T cell exhaustion that might be exposed because the lymphoma itself is now upregulating PD-L1. And so this was kind of priming the system with Pembro to block that exhaustion signal, as well as targeting the well-known resistant mechanism for CAR T cells, which is CD19 loss on these B cell malignancies. And so this looked at a single-arm, open-label, phase 1/2 study looking at safety, efficacy, and early outcomes in these patients. It was a small study, mind you. CAR T cells. This is kind of really advanced stuff and kind of hot off the press in a sense here. And so basically, it had a dose escalation by delivering more and more CAR T cells, and then they started to modify when you give the Pembrolizumab dose at day 14 or at day -1 and kind of prime the system ready to go. And so ultimately the recommended phase 2 dose was found to be this highest dose of CAR T cells, as well as the Pembro at day -1. And so you could see really sick patients with high-risk disease, transformed disease, and relatively bulky bulky disease with 22 sum of product diameter of the lymphadenopathy, and relapsed refractory patients there. And many had prior auto stem cell transplant, and the number of prior therapies was 3. So very sick patients, high IPIs, and these are our CAR T cell patients. So this was very consistent with other studies. What they found was, neutropenia was significant. I don't know about the lymphodepletion that was given on this, but potentially maybe some of it's due to that. CRS was relatively low in terms of significant, because it was present, but by this potential theory of knocking down the PD-1, you might enhance CRS. That didn't necessarily translate to that, and so the majority of these were low-grade CRS. And essentially steroids were given, and I don't think any tocilizumab was given. I could be wrong, but I want to say in the presentation I remember hearing that. And so importantly, when you look at the efficacy, you start to see CR rates at these higher doses. You see them even at low doses, but you start to see that the response rate starts to pick up a little bit. And most of these responses, if anything, are starting to be converted into complete remission. So maybe the needle was moved. Again, really hard to say. Small numbers of patients, but their overall response rate was encouraging, with high complete remission rates in the 48 to 50% range, which, as a barometer with conventional CAR T approaches, are in this 25 to kind of 35% range. So this looks maybe better, and it seemed to be well tolerated, and some of the fears that we had didn't seem to play out necessarily. And then getting to that hypothesis with the Pembro arm, it may even actually augment this response a little bit. So a lot of thought-provoking evidence here, and I commend the study design and the patients that enrolled, and so very encouraging data here and exciting to see. So so Dr. Brown, what do you take of this? And have you been using these bispecific antibodies or bispecific CAR T cells? And do you think are bispecific antibodies potentially going to supplant CAR T cells in a way, or is it an adjuvant, or how do you think of this field right now?
Interesting question. I think this presentation with the bicistronic CAR is very interesting for avoiding the mechanism or a common mechanism of relapse. And I was very worried about combining PD-1. So it's very nice to see that they don't have any grade 3-4 CRS, which is very impressive. Mm-hmm. The bispecific antibodies also look very promising. I don't know if they will have the same potential for durability that we have with CAR Ts. So I think that is still an open question. And certainly there's still CRS and tumor lysis syndrome seen with some of them. But certainly in terms of the relapse refractory diffuse large B-cell lymphoma, which has historically been such a problem, moving ahead with CAR T, and now also bispecific antibodies are coming to the fore, but still a lot of the activity in follicular lymphoma, but also in DLBCL. Yeah. It'll be interesting to see what the longer term follow-up looks like.
Yeah, no, absolutely. I agree there. And I think, they're attractive, and I think it's an exciting time that these agents are out there. And, obviously there's NK CARs as well that are allowing allogeneic kind of off the shelf production to potentially limit this delay to getting the CAR T cell delivery. So I think, the field is moving so quickly, and I think they're still trying to understand all of these predictors and biomarkers and which patients are best in which setting. And so I think, they're all going to be in play, and I think they're all going to be in the future. And it is kind of exciting to see how we're utilizing this immune system to attack these cancers.
Thank you very much, Dr. Brown and Dr. Allan, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, global conference coverage, Clinical Impact of New Data in B-Cell Malignancies from ASCO and EHA 2020, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.